I have the pleasure of introducing Dr. Martha Gulati. Dr. Martha Gulati is Canadian. She attended medical school at the University of Toronto. She went on to do her internship, residency, fellowship in cardiology at the University of Chicago, where she also received a master's in science. She's a fellow of the American College of Cardiology, the American Heart Association, the American Society for Preventative Cardiology, and as well as the European Society for Cardiology. In addition to that, she's a president of the American Society for Preventative Cardiology. She recently joined Cedars-Sinai as a professor in cardiology and the director of the Cardiovascular Disease Prevention. She's associate director for the Barbara Streisand Women's Heart Center, and she holds the Anita Dan Friedman Endowed Chair in Women's Cardiovascular Medicine Research. Previous to that, she was a professor of medicine. She was the inaugural chief of cardiology at the University of Arizona. She's had a prolonged commitment to the study of women and cardiac disease. She's won numerous awards and distinctions in that, including the first CREDO Award, which is the Coalition to Reduce Racial and Ethnic Disparities in Cardiovascular Outcomes, from the American College of Cardiology. She's the National Redress Award winner, and she's also the 2019 American College of Cardiology's Bernadine Healy Award winner, amongst many others. In 2019, she was chosen as the most influential woman in Phoenix. Because she's bored and she's got a lot of free time, she also likes to write, so she's also the author of the bestseller, Saving Women's Hearts. She served as a chair of the National Chest Pain Guidelines, and we're very excited to have her here to tell us more about women in cardiovascular disease. Is there really a sex difference?
All right, well, Dr. Chapura is a hard act to follow, but I do get to talk about my favorite topic about women and heart disease. So I hope by the end of this I convince you that there is a sex difference, and I have no disclosures related to this talk. So I think we all know, we've all seen this graph looking at cardiovascular disease mortality in the United States. And in the 1980s, we started actually recognizing that more women were dying from cardiovascular disease when we were seeing reductions in mortality from men. And this continued really until 2001. Now, we were getting very excited as we were seeing mortality decrease in women as well as men. But of course, as you look now, this is high tech. You see here in the most recent bit, concerning that cardiovascular disease mortality is increasing in both men and women. So all the gains that we have made in cardiovascular health, we're losing ground. And as we already heard by Dr. Chapura, we have concerns that this tsunami is coming. So of the 1.3 million deaths of American women, over 400,000 of those deaths are due to cardiovascular disease. The numbers are incomparable compared to the next leading causes: chronic lung disease, lung cancer, and the fourth leading cause of death is breast cancer, 43,000. Tenfold greater risk of dying from cardiovascular disease compared to breast cancer. But women, if you ask them what they care about or what they're worried about, it is always breast cancer. It is the thing that they know about, they know to get screened, they don't know to get screened for heart disease. In other terms, if you think about just the prevalence in American women of cardiovascular disease, it affects 13.8 million women. Again, the prevalence of breast cancer is 3.8 million. Again, I know this community here understands this, but it's a way for us to communicate to our patients and to the public about the need for understanding cardiovascular disease, specifically in women. Because for women, we have really taken a bikini approach to women's health. And this is a quote from Dr. Nanette Wanger. I consider her the mother of women and heart disease. And she said this when I was in medical school. She said, the medical community has viewed women's health with a bikini approach, essentially looking at the breasts and the reproductive system and ignoring the rest of a woman when we talk about women's health. Well, she said that more than 2 decades ago, and I'm still, I wrote an editorial recently saying, when are we actually going to listen to her? When do we move beyond the bikini and protect a woman's heart? Because we still see gaps in care, as I'm going to outline to you. So, first question I'd like to pose to you is really, do we follow our guidelines equally in women compared with men? We have guidelines. Unless they say that they shouldn't be applied to a woman, we should be using them equally. Well, we know a lot about this. We have our NCDR database, which is one version of getting data, but there's lots of other databases we've looked at. And so the best data that I can exemplify this with is with acute myocardial infarction, because that, we could look at many different disease processes, but acute myocardial infarction is something that we monitor. We're always looking at how good are we taking care of people. So for acute myocardial infarction, we know for women compared to men, women are less likely to go to the cath lab and receive PCI. They have longer door-to-balloon times. If it's a place that uses thrombolytics are used less frequently in women, and door-to-needle time is much longer in women. When we look at whether women get guideline-directed medical therapy, both within 24 hours of their acute myocardial infarction or on discharge, again, great disparities in the use of our life-saving medications. So it should be not surprising to any of us to see that women are more likely to be readmitted. And even when we look over time, although we've gotten a little bit better over time, these gaps in care persist. It's almost like you can't open up a journal where we tell you that, yes, there's still these persistent gaps. So again, mortality is higher in women, particularly in ST elevation myocardial infarction, and particularly in young women. Women under the age of 55, if they experience a STEMI, they are much more likely to die. And we also know this is a global problem. This is not an American problem. It is not a Canadian problem. We have data, and we just wrote a paper recently showing that anywhere where a country has collected the data and we're able to analyze it, and really it was only about Africa where we really didn't have good data, that we continue to see this problem. Part of it is we have biases when we care for women. And so just to show you some examples of these, this is from the National Hospital Ambulatory Medical Care Survey. This represents 29 million emergency visits of young people under the age of 55. So young adults who presented with chest pain. And what they found is that women, and also people of color, waited longer to be seen by physicians. So you can see that women were less likely to be triaged as an emergent case. It took 10 minutes longer for them to be evaluated. Women were less likely to get EKG or monitoring. They were less likely to be seen by a consultant, particularly a cardiologist, and they were less likely to be admitted. So if we don't take women's chest pain symptoms seriously, then, I don't know how we are going to remove the bias. You can look at secondary prevention after acute myocardial infarction. So this first study that you can see here on the left-hand side, this study looked at everybody with atherosclerotic cardiovascular disease, and a simple thing they asked, were they on a statin? And second, were they on a high-intensity statin, since the guidelines would say that they should be? Well, we do a crappy job with giving statins in general. Only 50% of patients were actually on a statin despite having a diagnosis of atherosclerotic cardiovascular disease. Then they also looked at the odds of getting high-intensity statin. And high-intensity statin, again, was only about a quarter of the population. But being a man meant it was more likely that you got a high-intensity statin. Now, the image over here, the image over here, this is looking at young people. So again, looking at people under the age of 55, comparing the odds of getting life-saving medications for women compared to men. And again, young women after an acute myocardial infarction, aside from aspirin, we're less likely to get antiplatelet agents, less likely to get lipid-lowering agents, less likely to receive beta blockers. So again, should not be surprising to us that women do less well. Additionally, when we look at rehospitalization, as the TRIUMPH study here demonstrated, they did demonstrate that women were more likely to be rehospitalized. And this is the time after the myocardial infarction on the x-axis. The gray bars represent women, the black bars are men, and the younger people are the solid bars, the people under the age of 55. So you can see that within the first month after discharge, after a myocardial infarction, these lines start separating within days. And they are greater for those who are younger. That younger women, not only are they less optimally treated, but of course that probably is the reason that they're more likely to be rehospitalized later. Also interestingly, when we look at the sickest women with acute myocardial infarction, meaning the patients who present in cardiogenic shock. Of course, we know many of these patients are going to die, but we want to pull out everything that we have to try to save these lives. And what we know from the national inpatient sample is that women, again, are in cardiogenic shock are treated differently than men. And again, the racial differences were also seen in here as well. So you can just look, women were less likely to get revascularized, less likely to get mechanical circulatory support, they're less likely to have a right heart catheterization, and women were more likely to die compared to men, again, with these racial differences. Now, there is many studies looking at implementation science, looking at how can we improve outcomes, how can we make people adhere to guidelines. And so this is one such study. I just like this one, but I mean, there are many that have tried to say, how do we improve these cares? How do we improve disparities? Shouldn't we be colorblind and sex blind? Well, this study, what they did is they did a 4-step protocol. They standardized their emergency department just to activate the cath lab when a STEMI came in. They also had a STEMI handoff checklist. And you know that for the emergency department, there's always shift changes, so everyone knew what had been done and what still needed to be done. If they didn't have a cath lab on site, then it was an immediate PCI transfer. And they also, in this study, did radial approach for the PCI because women tend to do better with the radial approach. So what you can see here on the x-axis, or on the y-axis, sorry, that is the percent of men doing better compared to women. And the blue bars are prior to the protocol, the red bars are after the protocol was in place. And you can see that these gaps really did go down when they used this protocol, when they put this protocol in place. The gaps didn't completely disappear, and still many of the measures women did worse, but you can see for stroke, actually women did better than men after the protocol was put in place. So again, these system-based approaches can work, and when we implement them in our hospital systems, it is a way for us to take away sometimes the bias that we don't even realize that is there. I wrote this editorial talking about things we could do to improve outcomes for women with STEMI because we continue to talk about these problems. Of course, we need more awareness in women in our communities to understand the need for timely care, but I don't believe it's the patient's problem. I don't think it's the patient who's done anything. It's, that's only part of the solution. The bigger part is how we respond in the hospital. We need our healthcare system to understand the need for timely care, the need for awareness that women too, including young women, can have a myocardial infarction. We need these standardized protocols as a checklist and a way to know and hold ourselves accountable. We need to think about artificial intelligence that you just heard about. Those, and I'm going to give you an example as well, but artificial intelligence may help us improve timeliness and adherence to care. And of course, we need more research, and I'll be touching on what we need in research in women specifically near the end. So I used acute myocardial infarction, particularly STEMI, as an example, but I could have used any cardiovascular disease and shown you different gaps. Just for an example, TAVR, in the early TAVR studies, what was remarkable with surgical aortic valve replacement, we know women have continued to do worse with surgery. But with TAVR, those studies were really exciting for those of us who care for women, because women actually did better than men after TAVR in all the partners trials. So it was exciting. Yet we know that we are less likely now to do TAVR in women compared to men. If we look at atrial fibrillation, women compared to men are less likely to receive adequate anticoagulation. They're less likely to receive NOACs. They're less likely to be offered rhythm control or ablation. ICDs, particularly CRTs, which again, the CRT studies showed that women actually benefited more from CRT implantation. Yet, who is more likely to get CRTs? Men. And when we look at heart transplant, women are only a quarter of the LVAD patients we have out there in the United States, and therefore only about a quarter of the transplants. Now, there is other reasons for that. I mean, there's choices that people make as well. But again, are we offering the therapies that we have up front equally to men and women? So then I'd like to shift beyond how we treat women. But how do women experience cardiovascular disease? Is it that women present differently? Well, specifically, again, moving back to acute myocardial infarction as an example. We've had in our sort of public community, we've conveyed this message that women present differently. But I think that somehow that has been wrong in a way that hindered women getting care. I also think in contemporary literature, we are finding more and more about the symptoms actually being quite similar. So just for example, the Virgo study. The Virgo study is a study of young men and young women under the age of 55, all of which had acute myocardial infarction. So they were able to ask the symptoms of those patients, and what they found was that women and men, both 90% of them actually reported chest pain. The difference between men and women was this, that women reported 3 or more additional symptoms. They were better at reporting their symptoms and giving quite good descriptors. But that was the difference. It wasn't that they didn't say chest pain. And we didn't know much about the under the age of 55 population until that Virgo study came out. Now, the high stakes group also looked at this. They looked at the symptoms. High stakes group is the group from the UK who brought us the high sensitivity cardiac troponins. And they were also able to collect the symptoms of the patients and know who went on to have a myocardial infarction. Well, women are shown in red and men are shown in blue. And what they found is actually more women had the symptoms that you would label as typical, the things that we would associate with having a myocardial infarction. So maybe women aren't so atypical. And then the Hermes study, which was presented at the same meeting as the high stakes trial at ESC, they used artificial intelligence. They listened in. They used a cardiolinguistic technology to listen into the conversation between the patients presenting with chest pain or any discomfort in the emergency room and their doctors. And what they found is that 90% of women and about the same percent of men did say the words chest pain. Again, women were more descriptive, but they did say the symptoms that we would expect. So for the chest pain guidelines, for those of you that have read them, we felt very strongly about this issue that, when we use words like atypical, they've been misused. A lot of times when people used to say to me, this woman has atypical chest pain, what they were trying to convey to me is they didn't think it was cardiac, not that they were presenting differently. Presenting differently, but still having a myocardial infarction requires urgent action, right? But it's been a misuse. So we made that a class 1 recommendation in the chest pain guidelines. We also said that the way we should describe chest pain is either as cardiac when we think it's cardiac, Non-cardiac if we clearly know it's non-cardiac, and possibly cardiac if we don't know. That at least is a better way to actually tell us what the potential underlying diagnosis might be or what workup needs to be done. And these recommendations were specifically put in to try to help us close the gaps in care for women that present with ischemic heart disease. We also put in the guidelines the issue about accompanying symptoms, meaning recognizing first that women are at risk for cardiovascular disease and that when they present with chest pain, we should at least consider that as a diagnosis. Seems straightforward, but again, given all the data I've shown you, women do get ignored. Secondly, we've said that women might present with chest pain, but they also will present with accompanying symptoms. And recognizing that may make us better listeners. It's not that women aren't saying chest pain, it's probably that we aren't hearing it. So then I'm a preventive cardiologist, to be honest with you, and so let's talk about things that we can do to prevent cardiovascular disease and understanding differences between men and women there. So in terms of our traditional risk factors, we know that there's differences in the risk factors and how they affect women compared to how they affect men. For diabetes, for example, we've known for many years that a woman who has diabetes is at a higher risk of developing cardiovascular disease compared with men. So appreciating that difference, maybe we'll have a heightened sensitivity for caring for women with diabetes. Hypertension has also been shown to have an elevated risk in women for the cardiovascular consequences. We don't know so much about lipid differences based on sex. Those don't seem to appear, but as I already showed you, lipid-lowering therapy is less likely to be utilized in women compared to men, and that's true for primary prevention and secondary prevention. Exercise, some of the early work I did was looking at fitness in women and showing that women's fitness is less than men and actually may have a greater consequence to be have a low fitness level and to die. So we need to be asking about that. And diseases of inflammation like lupus and rheumatoid arthritis are diseases that are more female predominant. So these are conditions that we should be asking about when we're trying to assess risk of cardiovascular disease. Now, when we do calculate the ASCVD risk, most of us have this on our phone. I hope we use them, and even on all our electronic health records now, it will spit out your 10-year risk as well as your lifetime risk. But aside from entering male or female, that's kind of all you have in terms of sex differences. Now, what was really good about the 2018 update is that they actually said, yes, still use this risk calculator, but there are things that you need to consider after that. This is just step one. The next step is to take into account risk enhancers that might exist. So risk enhancers, many of them were actually female specific that we should consider. One of them being pregnancy. And so pregnancy-related cardiovascular consequences are a huge issue in the United States right now. We have these pregnancy-related mortality that is similar to developing countries, and even our neighboring country, Canada, does not have maternal mortality rates like this. A lot of the things that young women are dying from are actually cardiovascular disease. So I do see this as our problem as well. It's not just an OB-GYN problem. We know that these differences in maternal mortality also have racial differences, particularly our Black population seems to be disproportionately affected. And when you look at what women die from during pregnancy, the majority of them, see everything that's boxed here, is a cardiovascular consequence. The majority of them are that. So we need to be involved. We need to be front and center with these issues that are affecting our young women. When we talk about maternal mortality, we're talking about the full year even after they're pregnant and after they deliver, because those are very critical times, and we know specifically from the California data has shed the most light on this, where they follow all the deaths in the state of California, and many of the causes of deaths are preventable, is what we found from our own data. So you can just see, this is again from the California database, and they looked at how many of these conditions that women died from in this state, how many of them could have been prevented. They looked through their records, saw who had symptoms, who presented to doctors, and they found that 63% of overall causes were preventable, but if it was cardiovascular that they died from, which was the majority, 68% of them were preventable. And while they were pregnant to 42 days postpartum to 1 year, you can see still the majority of them were preventable. But we just, again, our healthcare system has a lot to do with this as well that has affected them. But from that, we created this, sort of red flags. What should we be listening to for young women who have just delivered that might have something cardiovascular going on? Those red flag symptoms are listed there in the flag: chest pain, dyspnea, orthopnea, etc. There's physical findings that we should be looking for as well that should have a heightened degree of awareness and prompt people to ask for not only maternal fetal medicine, but possibly cardiology assessment to make sure there's nothing going on that we can treat. And rather than dismissing them or telling a pregnant woman, we know you're just tired because you have a newborn baby, that's not why they came to an emergency room. No new mother will come to an emergency room, doesn't have the time unless there's actually something critical going on. So the other thing, though, about pregnancy is it also helps us predict future cardiovascular risk. It's effectively a stress test. It tells us who's going to develop heart disease in the future as well. And I think those are the group that is very interesting for someone like me as a preventive cardiologist. This is the people we should be focusing a lot of our preventive efforts on, knowing that they're at risk for cardiovascular disease makes it a target group to ensure all cardiovascular risks are controlled. And when I say the risk for cardiovascular disease is increased, I'm not talking when they're 70 or 80. We're talking in the next decade. These are the premature cardiovascular disease events that we see in young women. So, this is published in JACC, just looking at all the risk factors that we identify that we should be screening for: preeclampsia, gestational hypertension, gestational diabetes, preterm birth, and small for gestational age. These are things that we should be actually screening for and also working collaboratively to try to prevent cardiovascular disease. Just to give you just a little bit of data, where did that data come from? This is from the Northern Finland cohort. This is every woman who delivered in 1966, and they looked at any type of hypertension compared to normotensive during pregnancy, which is the black line at the bottom of these curves. Any type of hypertension increased your risk for cardiovascular disease, chronic kidney disease, and diabetes. So they were able to follow these patients for a long, long time. We've seen this from the Caliber study in the UK, representing 1.3 million UK women. They also showed the same thing as that study, but they also were able to find things like atrial fibrillation and heart failure, not necessarily just atherosclerotic cardiovascular disease that was heightened in those people who had any form of hypertension during pregnancy. Gestational diabetes, this elegant study, and other studies have shown this, but this is an elegant study out of France. They followed all women who delivered from 2007 to 2008 in France, and they compared those who had gestational diabetes to those who did not. And those who had gestational diabetes in just the next 7 years had a greater risk of myocardial infarction, stroke, and angina. Just the next 7 years, you young women. We did this work on preterm births, looking at the risk of maternal cardiovascular disease, and we found that if you had a baby before 37 weeks of gestation, it was a greater risk for cardiovascular disease, but even higher if it was before 32 weeks. And again, the mechanisms, I think we're still trying to determine. We do think there's something that's activated during pregnancy. Pregnancy is almost a disease of inflammation. It is a heightened inflammation time point in life, but it does increase. This might be something is activated at that time. But importantly, what we should be doing is just recognizing right now that these women are at risk for stroke and heart disease. How can we screen them? How can we try to prevent cardiovascular disease in them? So we talked about this in a paper that I wrote with the ACOG community. There's two obstetricians and myself as a cardiologist, where we gave a statement about the fourth trimester. And we coined this term actually in that. And I love to see that people use this term of the fourth trimester. It doesn't mean just a 3-month period, though. We just mean the entire time after pregnancy. But what other health concerns we need to be addressing in that time period, and many of them are non-cardiac, but the biggest ones that we felt were really important was assessing blood pressure, the long-term risk of adverse pregnancy outcomes, and the risk for cardiovascular disease. And I think that's where we need to get more involved in their care. So when I think about prevention, I think about it across the lifespan, depending on what patient I'm seeing. If I'm seeing young women, I think about the risk factors at that point that might be present. I think about the women I see in the reproductive years, and we have a very strong collaboration at Cedars-Sinai, seeing the patients postpartum. Every patient comes to us who has any hypertension during pregnancy. And then for older women, we need to ask about those specific risk factors. So the last thing I wanted to touch on, though, was really about including women in cardiovascular trials, because a lot of that has affected what we know about cardiovascular disease. And I love this cartoon. I'm sure many of you have seen it. They say we have studies of fruit flies, mice, hamsters, frogs, monkey, and men with this condition, but medical research using women just never occurred to anyone. We're only 52% of the population. But, back when Bernadine Healy headed up the NIH, and she was a cardiologist, she talked about this and wrote this wonderful editorial called the Yentl syndrome. She used the story of Yentl. Yentl wanted to study the Talmud, but she was a woman. And the only way she could was to disguise herself as a man, to be taken seriously. So her point was, do women have to just be just like men in order to be taken seriously? Are we not allowed to have differences? And where are they in our studies? And she was hoping, and as she wrote this, is our hope that this will be something, this syndrome will be something that will slip back into history. I regret to inform Dr. Healy that it still hasn't. We're still dealing with the Yentl syndrome right now. When you look at this trials that are done globally, and there's also a paper that looked at trials in the United States specifically, but this one looked globally, and they found that it didn't matter what type of disease that was being studied, except for pulmonary hypertension, where we've over-enrolled women. Other diseases, particularly heart failure, has the lowest enrollment of women, but coronary artery disease has the second lowest enrollment of women. It doesn't matter the intervention type. Less women are put in all types of trials. It doesn't matter where it's done globally. Everyone seems to not want to enroll women. It doesn't matter if it's a small study or a large study. It doesn't matter really about age, although we've gotten better at getting people under the age of 55 into trials, so that's at least some good news. But given that cardiovascular disease disproportionately affects women in the older ages, we still need to get them into those trials. And sponsor type didn't matter either, although interestingly in this, when the government was involved in funding, there was no accountability. And you can see that that's where you have these lower inclusion of women was when the government funding was involved. And I don't mean just NIH, because this was a global study. It was any government funding. So why does it matter? Well, sex matters, right? Biological sex. Every cell has a sex, and therefore every gene and every molecule is influenced by what your biological sex is. We should know if somebody is a woman who is XX versus XY, how will they respond to the medications we're giving? How will they respond to interventions? And gender also matters. Gender, how you're seen in society, and that's a social construct. But how we're seen by our society influences the care, influences the bias that is introduced every day in how people treat people, their access to health care, their employment, etc. Both matter, and that's the reason that we need to be inclusive in our trials, because we are not understanding everyone by just studying men. Heart disease, I used ischemic heart disease today to show you some differences, but we're just at the earliest stages of understanding even the patterns of ischemic heart disease. Women are less likely to have obstructive coronary disease, and they're more likely to have ischemia with no obstructive coronary artery disease or ANOCA. And again, all the things that we talked about, the difference in risk factors, the difference in presentation, what we'll see in the cath lab, SCAD, for example, much more frequently seen in women. The lower plaque burden also seen in women. The differences in the access to care that I already showed you, that we treat women differently than men. And that ultimately that influences the differences in outcomes. So this is just an example of why we need to be doing research, because now that we're studying women, we're getting far more information that's hopefully going to translate into improved care. If we don't care about sex, we will never understand. This is just a paper that we wrote actually specifically about heart failure, but we talked about why would drugs work differently in women? Well, there's sex differences in absorption, distribution, metabolism, and elimination of drugs. And by pregnant women are different than regular women, who are different than men for many of the different ways we metabolize medications. If we don't understand that, we'll never understand why there's differences. Just an example of common things, hypertension, we all deal with hypertension. Our hypertensive medications here, you can just think about diuretics. In women, a higher plasma concentration of diuretics should be surprising that women have more electrolyte disturbances and more arrhythmias. Beta blockers, again, the plasma concentration, the clearance is less in women compared to men, and therefore women tend to drop their heart rate more to beta blockers and drop their blood pressure more at the same doses. Women will have more side effects if the metabolism is different, and we need to be reporting that when we study drugs. And I think this is just examples I wanted to give you from something we do all the time. Now, why have we excluded women? I'm just going to give you a very quick historical perspective. In the 1960s, perhaps some of you will remember or know this drug called thalidomide. Thalidomide was used in Europe it was there for morning sickness, but unfortunately caused adverse effects to the offspring. So almost immediately in the United States, really after this drug appeared and that people understood it, in the 1970s, the FDA said women of childbearing potential are excluded from trials. And that became actually more like women are excluded from trials because people were scared to include women in there. So in the 1980s, the FDA sort of changed its position slightly. It actually made a call to action for specific subgroups, but it said nothing about race, and again, it said nothing about sex. The NIH started encouraging that women be included in trials, and in the 1990s, under Bernadine Healy, certainly she made a push. She made an Office of Women's Health Research. She went to Congress, and Congress mandated the inclusion of women in trials, but they held no one accountable. That's the problem. In the 2000s, FDA actually called for pregnancy registries because we realized we'll never know anything. We never study pregnant women. How are we going to ever know if these drugs are effective or safe in pregnant women who really need them? So they started a registry. That was the first step. In the 2010s, the FDA made a call for expectations in medical devices in terms of reporting. If they had women in their trials, please report that information. But then in just last year, in 2022, is the first time formally the FDA said and gave a framework for sex and gender and device reporting. And the Institute of Medicine also in 2022, which was just last year, also made a statement similar to the FDA. So you can see, I just wanted to show you that because we're really just catching up. And even animal studies and cell line studies, believe it or not, until 2016, there was no requirement to include female animal lines or female cell lines. Now it is a requirement since 2016. So it's kind of like we're doing our work a little backwards, finding out now about cell differences and animal differences. And then hopefully this will translate to human. And guess what? The mice also get pregnant. They also have different hormone levels. So this will help us take care of women by the fact that the NIH has made this demand of investigators. I just want to end with this last thing though, is that this, even despite all the things I've shown you, this is where all the drugs that have gone up for approval, just the percent of women included. And this yellow line down here is cardiovascular disease drugs. 2019. 2020 is less than 20% inclusion. So we are just a little bit over 20%. So no one's keeping people accountable. You look at GI, that's the bright orange line. They've done a much better job of any of these new drugs. So until we hold people accountable, until we demand that women are included in our research, this will remain a problem. We'll never know how things are different. So getting women into trials is a big topic right now because we really want investigators to think about it. And that's both from a diversity standpoint, because we know people of diverse backgrounds are also underrepresented in our trials. So we've written some papers about ways that investigators could think about improving the enrollment of diverse populations, which includes, again, more cardiologists as investigators and more diverse people as part of the investigative population. But also, thinking about how will women get enrolled in this trial. And during the pandemic, we found when women didn't have to come in for research, they were more likely to be involved in trials and have the time for them because they could do them easily. So I think these are the things that we just need to think about to improve the care of women. We need more women in our trials. We need to apply guidelines equally in women. We need to think about bias in our care and try to reduce that gender bias. Women's heart centers may be also helpful for us for care of women. And of course, following our metrics, that will help us. We should be looking at our own hospital metrics to ensure that we're not part of the problem. That's what I often get asked is, well, we do it at our hospital. We don't have any bias in care. I'm like, look at your data because you do. So that will be the way that we improve the care for women. So I hope I've convinced you today that there are sex differences in cardiovascular disease. And I think the one thing, if we just take home, is to apply guideline-directed medical therapy equally in men and women, we will save lives. I hope I've also taken away from your vocabulary atypical. Please don't use that anymore. And I hope that I've also shown you that women are understudied, underdiagnosed, and undertreated in cardiovascular disease. And if we don't close those gaps, we are not going to be able to save lives. So again, thank you so much. And Dr. Khan, thank you again for having me here. I was just honored to be here.
We'll take questions now.
You might have to repeat the question because I can't.
Yeah. The question is about hormone replacement therapy in cardiovascular disease.
I said in my primary care practice, a huge thing that's like a gender or sex discrepancy, whether it's trans or feminization or biological, et cetera, is hormone replacement therapy and the risks. Because I know in the 1990s, there was a huge guidelines that were like, don't do it, especially in high-risk populations for women, increases cardiovascular disease, among other things. And now I'm hearing a ton of discordant information, especially from the GYN colleagues I have, about that's mainly white male, researchers were doing that, and it actually isn't as, prevalent. It's like this huge movement from what I've heard, and that's a huge thing that I have to prescribe along with, GYN, and it's always been like, well, quality of life over, but I'm like, is it really as dangerous? Like, do you know about
Yes.
I'm assuming it's retroactive trials?
So I was part of the Women's Health Initiative, so it wasn't all white men.
Okay.
And there's actually a lot of women.
That's literally
actually.
what I was told.
But that study, as you know, came out in 2001, and that was the year that we saw a reduction in mortality. So part of, the number one prescription in the United States was hormone replacement therapy. And in 2001, almost overnight. I remember that day in July, I think was the time when our results came out, and overnight it was amazing what happened in terms of that. Now, was the Women's Health Initiative a perfect study? Absolutely not. They enrolled people that weren't just going through menopause, but just anybody who was postmenopausal. So there is some found criticisms. I think that I will also say that it was an imperfect study. It also wasn't using hormone replacement therapy that we currently use, lower estrogen doses. What we do know from the WHI, and we'll never reproduce that was such an expensive study, and it was such a big study showing women would actually participate in research. But we do know that it doesn't prevent cardiovascular disease. That was before, you might not realize this, but people were being told that this was the fountain of youth, and this was going to save women. So from a prevention standpoint, we shouldn't be using hormone replacement therapy. But we should feel reassured for women that are going through symptoms that require hormone replacement therapy for quality of life, that those were the people that probably at least did not have harm and maybe even had some benefit, but mostly that they weren't harmed by the use of HRT in the WHI. And given that we are using lower doses of estrogen in the current forms of hormone replacement therapy, I think we agree with that. We want patients to be on HRT for the shortest duration, but based on their symptoms, that will be a conversation between them and their gynecologist. But certainly sometimes cardiology gets asked to weigh in on it. And certainly for some patients who are at high risk for cardiovascular disease, but definitely those with cardiovascular disease, we actually try to encourage our patients to get off of them.
Any more questions?
Great talk.
I don't know if we can. I'm going to have a hard time hearing you too, but I know who you are, Vermont.
Great talk. I just wanted to ask about SCAD. I know that in your initial slide you talked about STEMI and...
Can give him a microphone? I'm sorry. Sorry, Vermont.
In your initial slides, you talked about STEMI and how difficult it was to tease out women and how to get them treated appropriately and in a timely fashion. Has there been any studies regarding SCAD, especially with, again, women's pathophysiology of coronary disease is a little different and sometimes kind of confounding. So has there been any thought about looking into that, especially when they present to the emergency room with their symptoms?
In terms of their symptoms for SCAD?
Yeah, and then recognizing.
Yeah, Dr. Saw, I think, is one of the big investigators in the SCAD group, as well as Dr. Sharon Hayes here in the U.S. And I think that, in terms of presentation, they present just like a myocardial infarction. And so they're the ones that only because we get them to the cath lab do we realize that they're having SCAD. I think there's an increasing recognition now of SCAD, and I think we're seeing it's not as rare as we used to think. But in terms of symptoms, we don't have any data that suggests that they present somehow differently, that there's something that you can pinpoint that this is definitely SCAD.
Yeah, that's the problem. You can't really tell from the symptoms alone.
Yeah, until you have the anatomy, you don't know.
Right, exactly. The other question that came up was your use of AI, which I thought was brilliant. And going back to Dr. Ichipuria's great talk, you mentioned the fact that there was difficulty from the women in studies to participate in the studies because of their lifestyle and how many responsibilities they have at home. So do you think AI would impact positively on their participation, and then we can then get more?
It depends on the study, right? I mean, what I think about the studies is when we design them, we should think about participation and inclusion. And that includes not just women, but people from diverse backgrounds. What will make them participate? We need our patients as part of our study panel, like our advisory boards, because they will tell us, oh, we would never do that, or we would do that. That's easy for us to do. I think, a lot of research that, again, Dr. Ichipura talked about, when 90% of people now have smartphones, what data can we collect from them where they don't have to do too much? But how will that help? How will that make it easy for them? So I think there's a lot of questions that we need to answer to make it easy for people to participate and less complicated and less costly too. Research has become, something that, if you can't afford to do the study or you can't afford to do it in enough patients, then what you find may not be translatable. So I think that this is where the AI or digital transformation is also important, not just in our care, but also in how we do research.
Yeah, the barriers are the issue, and I'm glad you brought that up. Thank you.
Any more questions?
I had two questions. In regard to the Virgo study,
Yeah.
you talked about 90% of both young men and women have chest pain, but you said women often have, 3 or more other symptoms. So is there any common trend to the other symptoms that might help us care for them?
Yeah, the commonest symptoms that they experienced, at least in that population, was shortness of breath, neck pain, and fatigue. And again, the big issue with that is that chest pain may not be their presenting symptom. Like the shortness of breath might have brought them to the emergency room. So chest pain, but if you ask them about chest pain, they had it.
Is it still true? I was always taught that women often, instead of saying they have chest pain, they might have more epigastric pain or fatigue.
Yeah, I mean, definitely, what I say is that you have any discomfort above the belly button, you need to rule out if it's cardiac, especially if they have risk factors.
Perfect.
So,
okay. And my second question was, you had that interesting slide about almost 50% of people with ASCVD are not on a statin. And I was curious if they delineated how many of those were offered a statin but declined, because at least in my population, I have a lot of women that are, in my population, much more active and healthy. Like they walk 3 to 10 miles a day, and they're really resistant to statins. So I offer it 10 times, and they always refuse and say, no, I'm gonna exercise. And
yeah, no, it definitely is a challenge. It's a challenge for both men and women, and there is side effects. And even if they're nocebo side effects, as we've demonstrated in the Samson study, where people, even when they were on placebo but they didn't know, they still reported the statin associated side effects. Even if I explain that to patients, I can't win necessarily on every patient, and women definitely have more statin associated myalgias than men. So, I think it is a challenge. I don't know for that particular study. I know that they don't know that information actually in that particular study. But I think that what we need to do with our patients is really spend time educating them about why we're asking them to take statins. There's a lot of stuff online saying that all of us are getting kickbacks from statins. I don't know what statin, because they're all generic, but, but we're not, we need our patients to also help them manage through all the information that you can get by Dr. Google. And that really is a big problem too. But I think the great news is that we can lower LDL these days with so many new drugs. So if they really don't want to be on a statin, we have so much more than we had a few years ago. I mean, a few years ago, statins were it, and then Zetia came along. I guess we had 2 things. Now we have many more. So I try to work with them, because I do understand that if they're not going to take it, I'm not going, at a certain point, I'm not going to win that fight, but maybe I'll win with another medication that is a non-statin therapy. And that's the way that I view it in my approach to patients.
sorry, that was such a good point. I had a third question that came up. Is it okay if I ask it? So I have had a lot of luck with patients who refuse statins and want natural approaches, being open to red yeast rice or Zetia or bempedoic acid. But I've had trouble finding out, is there proven mortality benefit with any of that? I know there's a lot of research for statins having mortality benefit, but
Yeah,
those
no-
other ones.
Yeah, I think now all new drugs are being held to the same standard. So we are, getting more and more information. Zetia, for sure, we do have data that reduce cardiovascular events. And that's how it got second in the guidelines, partially because of it having the data, the randomized control trials, but also partially cost, to be honest. They could not put PCSK9 inhibitors at the time that those guidelines were written as a second choice, even though we actually probably had the data, mostly related to the cost. Now, we find even insurance companies, given the cost, they don't always ask us that somebody has to be on Zetia for them. But I think that it is an exciting time for all of the medications we have. And I think that you should be thinking about alternatives just because of it. Now, the red yeast rice issue, of course, that's how we found lovastatin, was through red yeast rice. Always drugs often come from something natural. The problem with red yeast rice is that nobody's following it in the United States, right? Anything over the counter is just over the counter. And we've had cases published in our respected journals showing cases where not only did patients get fungal infections from red yeast rice that they bought, but they actually went into kidney failure, and it was permanent. So, I get very concerned about that. I try to communicate with patients that, look, that's just a statin that you're taking. Why not try a statin that's actually followed? And, we do win in some people. They don't realize that. Technically, in the United States, red yeast rice is not supposed to have the active component, but again, because nobody follows it, because nobody follows anything over the counter, they don't. There's many versions, most versions have the active component.